Welcome to Hacking Hypermobility Podcast.
I'm Luna,
And I'm Shelly,
and we're Two Bendy Mommas.
Hacking Hypermobility.
Hey, don't scroll. Stop. I need just like 1 minute of your time tonight. I'm going to tell you why I make all this Ehlers-Danlos and joint hypermobility content. It could save your life. There have been multiple studies, but I do want to share and summarize this particular study where scientists have evaluated the vascular presentations of EDS in the phenotypes not known as vascular EDS, all the other things, including hEDS. So hypermobile Ehlers-Danlos patients, listen. So in this study, they looked at all of the known genetic variants and different vascular presentations compared on this chart. Let me zoom in. So they evaluated vascular complications in non-VEDS patients, including those listed here. And some of these are like no big deal for us. I mean, the biggest chunk of those are hematomas, bruises. We know we bruise, but look at the rest. Yes, we are at risk for dissection, aneurysm, and other scary vascular events. Now, I'm not telling you to stress out. However, look at this figure. Overall, in this study, 17% of Ehlers-Danlos patients that aren't VEDS patients, vascular EDS patients, had a severe vascular complication. Those complications were most seen in certain types of EDS patients. They were most seen in MC EDS and classical-like EDS, CL EDS. Now keep in mind, this data study was done before the genes were identified for hEDS or hypermobile EDS, and those still haven't really been released. However, did you know that all Ehlers-Danlos and hypermobile patients should be treated as a vascular EDS patient when presenting to an emergency room for concerning symptoms? Also, did you know that there are separate genes for an inherited thoracic aortic disease? You are at greater risk if you have one of those syndromic diagnoses such as Marfan's or vascular EDS, but also there are non-syndromic genes that are seemingly independent of the known heritable connective tissue disorders that affect your aortic health. I actually carry one of those as well. And I have a theory that some of us hEDS patients probably have this on our cluster of genetic makeup. But that's just a theory. That's not science. The rest of that is science. You need to be treated as a vascular patient if you have EDS or hypermobility.
And that brings us to our third and final criterion on the hEDS diagnostic checklist. Okay. And it includes 3 key points that exclude other diagnoses. You will sometimes hear hEDS called a diagnosis of exclusion, and this is why.
Okay, well, how do they do that?
So this checklist is designed to be like an algorithm, basically. It ensures other things are considered. So this is the portion where they look at signs and exclude other disorders by going through some of the more nuanced symptoms. So you have to check off all 3 of these parts in the last criterion to be diagnosed with hEDS. And any of these signs would indicate you need to be evaluated for another type of connective tissue disorder instead. So the first one is the absence of unusual skin fragility, which would prompt consideration of other types of EDS. Number 2 is the exclusion of other heritable and acquired connective tissue disorders.
How do you acquire connective tissue disorder?
So that would be an autoimmune or rheumatological condition. There are rheumatological autoimmune disorders, including lupus, rheumatoid arthritis, and there are connective tissue disease that a rheumatologist would evaluate for you.
My rheumatologist wanted nothing to do with me and my connective tissue disorder.
So some rheumatologists are not comfortable evaluating or managing connective tissue disorders or disease. They tend to focus only on immune stuff or only on disease and not genetics. disorders.
Right.
There is not a lot of support to medical providers in terms of education or standard protocols, that sort of thing, for evaluating and managing hEDS and hEDS. So it's kind of a narrow specialty. We've been increasing demand by demanding awareness and spreading awareness. And those providers that don't feel competent in that are pushing back and saying, hey, I don't have the specialty understanding to treat this for you.
That's fair.
Now, is that ethical? It's another conversation.
Yeah.
Yeah. So feature C of Criterion 2 be the chronic pain and instability in your joints cannot be counted towards a hEDS diagnosis in this situation. Okay. So if they determine that you have lupus or rheumatoid arthritis, they will attribute the chronic pain and joint instability with
that.
those
Okay.
rheumatological conditions, and it will be marked off that part of Criterion 2.
Okay.
What's interesting, by the way, and this is one of my concerns, hEDS patients are 40% more likely to have an autoimmune condition.
Yeah. Like both
Such
of my
as
parents
horrible.
have one.
Anyhow, so moving on. So the third one is exclusion of alternative diagnoses that might also present with joint hypermobility by means of a hypotonia or connective tissue laxity. So alternative diagnoses, diagnostic categories are not limited to, but these are the things: neuromuscular disorders, Bethlehem myopathy, Ulrich myopathy, and you and I believe, both have.
I have
mutations on
alleles
this.
for both of those. Yes.
Yeah. Okay. Neuromuscular disorders can fly under the radar, but
I
many
think
of
that
them-
might be what I'm dealing with, actually.
Other hereditary disorders of connective tissue, including other variants of EDS, Loeys-Dietz and Marfan syndrome, skeletal dysplasia, in other words, something like osteogenesis imperfecta, which does present similarly. Not to confuse, hip dysplasia is a hallmark of arthropelagic EDS.
Yep. You have it, and my sister was born with it.
Mm-hmm.
Okay, so your doctor, you have one of these things. Now
so my experience when I went through this was they stopped and they were like, there's something going on here. This is not just hEDS. Okay. So exclusion of these considerations may be based on history, physical exam, and molecular genetic testing. So for me, once they went through my history and exam, they said, oh,
yeah,
let's look at your genetics. And then it got more confusing. But that if you have something more rare, that's what this algorithm is intended to do: filter you through all these things and then say, okay, there might be something more here.
They ran my genetics too because of my grandmother and my mom's issues. They were thinking, and my sister being born with hip dysplasia, they were like, let's just make sure.
So if your doctor identifies any of these other signs, they may take some additional steps, like what Shelley and I did, and be referred to genetics evaluation. So suggestive findings would warrant your health journey taking a further path to evaluate you for another type of EDS or heritable connective tissue disorder, or maybe even, like Shelley said, the neuromuscular disorders. Indications for a referral to geneticists for consultation and possible genome testing for signs of more severe presentations, may be your next step, but not everybody will end up being referred to genetics. The exclusionary criteria, such as the absence of unusual skin fragility, heart frailty, can help identify, for example, when you might need evaluated for the more rare types of connective tissue disorders. There's some key signs of like vascular EDS, aneurysms, dilated aortas, what I deal with, the very translucent skin, which is seen in my daughter and I, and some vascular presentations led to us bone dysplasias. Yeah. So that's why we were further evaluated. And so I am not officially a hEDS patient. However, my geneticist has flat out come and said, like, Don't be surprised if when they find a gene you have it.
Yeah.
So while not diagnostic, there are also some other tools providers have learned to use to help, you through the diagnostic process from, the medical literature and research.
And so,
So
like, what would they, if they're forward thinking and have all that stuff, what other considerations might your doctor like consider and notice?
So beyond just those things on the hEDS checklist, your doctor may go through things we discussed in previous episodes, the alternative screening questions for hypermobility. There's also this acronym called JUST GAPE, GAPE.
Just GAPE. Okay, I have to check
yeah,
that.
These questions are from the UK GP toolkit that they use for
cool.
hypermobility. J is for joints. U is for other soft tissues.
Okay.
I know. Other is starts with an O, but okay, it's phonetic. Okay. G is gut issues.
Sorry, I can't. Okay.
Yeah.
U is for O. Okay.
A is for allergy and
Oh.
autoimmune issues.
Mm.
P is for postural symptoms.
Yes.
And E is for exhaustion. I mean, that's not on the hEDS checklist.
It's not.
Fatigue. And I would
should
say
be.
that is a hallmark sign.
Yeah.
But it can be a sign of many other things. But the point is,
I
the
thought
Just
it was a
GAPE
sign
acronym
of
is
me
putting all those things
being
together.
a mom and with 2 kids.
Yeah.
I thought that's what that was.
You're just tired because you have a busy life.
Yeah. Okay. I just woke up and I'm tired, but sure. All right.
Yeah. I hurt more when I wake up.
Yes, sleeping hurts, man.
Yeah.
What? It's November, mosquitoes. You can fuck off.
Also,
What the hell?
if you tend to have weird allergic reaction to mosquitoes.
Yes, they love me. I wonder why.
Other weird allergies, such as sun allergies,
Mm-hmm.
aloe allergies,
Metal allergies.
IgA deficiencies,
Yes.
IgE deficiencies,
Mm-hmm.
without having
or lower ones. Like
yeah,
my IgA is the only one that's ever low.
yeah, yep, fun times. That's not uncommon on us.
Yep.
Anyhow, so many other features are described in the hEDS literature, but most aren't sufficiently test specific or test sensitive to be included in the formal diagnostic criteria at the moment. So there's just not enough research or understanding of it. These include, but are not limited to, sleep disturbance, fatigue, POTS, postural orthostatic tachycardia, dysautonomia, functional gastrointestinal disorders, anxiety and depression. These other systemic manifestations can be more debilitating than joint symptoms, right? We discussed that. Like, they often impair functionality, quality of life, should always be determined during clinical encounters. While they're not part of the hEDS diagnostic criteria, the presence of such systemic, wide-ranging symptoms across your whole body and multiple body systems should really prompt a consideration of hEDS and a connective tissue disorder. There's this phrase, the issues in the tissues. Okay. You can't connect the issues in the tissues. If you have a patient and you've got all these issues and you can't figure out what's going on, consider a unifying cause.
Yeah. One thing do those all have in common? Connective tissue.
So your doctor may order some other tests and evaluations for you to go do also.
Like what? Like blood work or imaging or
yeah.
Okay.
So they may do some blood tests to rule out some things, to test for inflammatory markers, autoimmune causes, hematologic, metabolic, endocrine, hormone issues, other causes of musculoskeletal issues, fatigue. They may do imaging, like you mentioned, like X-rays, which looks at bones, ultrasounds, MRIs, which may look at tissues better to help identify the causes or where your inflammation is, mechanical damage or failures, injuries, nerve impingement at your joints and soft tissues. It can help identify if there's a partial dislocation. We call that a subluxation, or bone changes. I have little like scars on my bones, little knobby things that cause
Oh,
further soft tissue damage from
yeah,
all the
my mom has some of those. They call them calcium deposits, right?
or endolistheses, like the bony deposits cause like spines, like, and
Like
they poke into my hip and like are now
like a hip
damaging the
spur
labrum. Yeah.
okay.
They're seen in the spine where the spinal hypermobility causes those little tiny spiny pokey things on the edge of your spine.
Yeah.
Those rub up against each other more in hypermobile patients, and so the bones actually become a little deformed, and you start to see those
Oh.
when they, check your spine. So they may also even do something called an EMG to evaluate your neuropathic symptoms, so your nerves. Okay. The other one we kind of mentioned already, vascular imaging, especially echocardiograms to check your heart chambers, the valves, and those connecting major blood vessels. And really, an echo should be done whenever a connective tissue disorder is suspected in hypermobility. It's being evaluated. Sometimes they may even do skin biopsy. That's becoming much more rare just because of how invasive it is.
Yeah.
And
Well, and if you have genetic testing, it can help.
Yeah. And what we really hope for in the future is a biomarker, a lab specifically, because they have identified some of the biochemical differences in our cell metabolism. They could potentially develop a lab test for it. It does not exist yet, but the research is there and developing.
Okay. So it's on the horizon.
Yeah. So those are a lot of steps that just like your primary care doctor could be taking. Yeah.
Yeah, but then like you go to the primary care and you tell them all of this and they're like, that's great. You should go see blah 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 specialist or a specialist, or I'm gonna write you orders for you to go see 6 different specialists because blah 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 blah. So like I have a shit ton of doctors. It's really annoying. I wish I had like a case manager. But so what other specialists, like what's
so in all reality, we're just going to be honest here and say it is really likely that your doctor is going to say, well, this is out of my lane. I don't fully treat this. I'm going to refer you to a consultation with a specialist. And because we have systemic issues, it's probably going to be multiple specialists. It may be a specialist, to look at your connective tissues. It may be a specialist to help with any of your like bigger symptoms or issues. So if there's a concern that may have a connective tissue disorder other than HSD or HEDS, they really should be referring you for an expert opinion,
what are those?
further. So
those are all of those things we just mentioned.
So there are some signs, and these are what they would consider indications for genetic testing, like we mentioned. So geneticists are currently the most adept at distinguishing between the different types of heritable connective tissue disorders, but they don't necessarily treat and manage us, but they just have most of the knowledge.
So they're like the lab person
who
comes up and then like puts forth and says, okay, now go take
They're
this
more
knowledge.
Diagnostic in ability and focus. So not every hypermobile patient or HEDS patient really needs to be seen and evaluated by a geneticist for diagnosis. You do not need to see a geneticist for a HEDS diagnosis, particularly at this time, since the HEDS gene
we don't even know what it is.
To be published. There is a proposed gene. It's not yet fully validated, so it's not published. But some clinical presentations within your own or family history may warrant a geneticist, like we talked about, to evaluate, this niche presentation. There are also really significantly long waits and access issues due to the small number of geneticists with this type of diagnostic experience.
Right.
So if referred, we want to prepare you for the wait or the need to travel or consult virtually. And some clinics that have EDS aware, connective tissue aware geneticists aren't taking new patients.
Yeah.
Or they're
limiting
patients to just the ones in their state or just things like that.
Johns Hopkins is no longer I think they might see you eventually, but my friend
They're
got a letter.
prioritizing.
They don't like. I was really lucky I got in when I did,
Got
because
it.
if they even suspect that you're hEDS and not something worse, then they'll just make you wait forever.
Yeah.
But I really think my grandmother's uterine rupture and brain aneurysm, they were like, and then my sister and my mom, they're like, okay, and I clearly have
Yeah.
issues. But
So
yeah, they're not.
there,
It's getting harder because of
yeah.
people
So
are much more
Shelley
aware.
touched on the things that clued in the genetics clinic that they would need to evaluate this patient. So there are some clinical signs. So the skin features we talked about, the classical signs, the very abnormal scars, very elastic skin, vascular signs, the translucent skin, skin that tears and has very abnormal bruises, very large or in strange sites, unusual facial features or phenotype facial dysmorphias, thin lips, overly prominent eyes, narrow nose, very downward slanting eye angles, in addition to skin fragility, very severe scoliosis. Like, I mean, like very bent over, very crooked, very, very, very pronounced scoliosis, much more than what you are experiencing.
Yeah.
The marfanoid body habitus, what we talked about, along with abnormal echocardiograms and
Okay.
lens dislocation, lens dislocations. A personal or family history that should lead to consideration of vascular EDS or
Yeah.
VEDS, which is the most fatal of the EDS variants.
Yeah.
So the vascular events include what is in both of our family histories. Aneurysms, subarachnoid hemorrhage is in my family history. Recurrent severe postoperative hemorrhage and arterial dissection. I am at risk for arterial dissection because I have a dilated aorta. Recurrent spontaneous pneumothorax.
What is that?
Lung collapse. Bowel perforations. So like
Okay.
your intestines having a rip and your guts opening into your body cavity, that can be very terrifying and death causing. Uterine rupture.
Yep.
Which is what was in your family history.
Yep.
Very severe peripartum perineal tear.
Ouch.
So that just means in childbirth, the skin below the birth canal rips open. It's very common, but a very severe level of that. And this isn't in this list, but one of the concerns they had was when I gave birth, I was delivering without contractions. And I ruptured my ureter, the tube that goes into the bladder.
Ouch. Oh.
But otherwise, I didn't have severe like postpartum bleeding or anything like that, by the way.
Oh. Well, that's good.
Yeah.
So what are the other I mean, I know all the specialists I see, but I know I don't have some of the issues other people have. So what are some of the specialists that you might get referred to?
So the other big one we mentioned is the rheumatologist.
Yeah.
So ongoing musculoskeletal symptoms despite pain management and input from physical medicine like PT indicate a referral to rheumatology for further evaluation. Some studies have shown though that there's a higher comorbidity of inflammatory and autoimmune diseases than the general population in hEDS patients. So hEDS is not an autoimmune disorder, but frequently presents with autoimmune and allergic disorders. Like you said, many of us have a team of doctors, and we may not have the same teams or types of teams. Many other specialists that might be consulted for management of your conditions include cardiology, cardiovascular, pain, neurologists, ophthalmologists, mental health, physical medicine, alternative medicine, allergists, gastrointestinal, urologists, pulmonologists, sleep medicine, ear, nose, throat, ENT. But of course, our presentations they vary. So this is not an exhaustive list. Those are just kind of the big ones.
That's a lot. It makes me tired. Like, I go see one doctor and they're like, have you seen the blah, blah, blah doctor yet? And I'm like, do you realize how many goddamn doctors you told me to go
I need
see?
to
Like,
pace
I'm
myself.
tired. I can't. Oh, and then like when they found that thing and they're like, well, now you need more imaging. Like, I haven't, whatever.
I've been putting some things on hold just because like I can't, number one, I can't financially manage all of that once. I can't manage all of that once, like in my own head and keep up with it
Yeah.
or emotionally keep up with it. And I can't take that much time off work. I can't like, it's like a level of commitment I was not willing to make.
I was joking the other day when I said I was in PT for my neck and I had been complaining about my hands. And then I asked my therapist a question about finding good compression gloves. And she said, well, I don't know. Let me talk to my hand specialist that we have here. And I was like, excuse me, you've had a hand specialist here this whole time. And this is the first time I've heard about it. So I ended up when I was done, I went to the front desk and I said, can you get me in for an eval? Like whenever, and they squeezed me in the next day.
Okay. So Shelly just touched on 2 more hypermobility hacks.
Yeah.
1, some of your best resources are going to be physical medicine therapists and doctors.
Yeah.
They know this presentation really well, and they know who to network you with.
Yes.
Number 2, in the US healthcare insurance, you no longer need a referral for PT.
Yeah.
You can just like call them up and be like, hey, also like funny story. I was in PT for my hip again for like the millionth time.
No.
And the PT was like, yeah, but I'm more worried about your shoulders.
Yeah.
But so
well,
trust their assessment.
Yeah.
And then I was in PT a whole other time, like a couple years later for, again, hip and pelvic stuff. And she said, you know, you don't breathe right.
I don't either. So the little tech guy who picks me up usually to get me under heat or whatever I'm going to do before I work with Tina was like, he came out here and he was like, you're seeing Raina? And I was like, oh yeah, my hands are jacked up too. He's like, go. But then the next day I had a pain management appointment. And the beauty of one of our other hacks we mentioned was, if possible, try to get all of your people in on the same network or at least same platform of shit. Yeah. So all of mine are kind of interconnected through the same hospital system. So they all have access to my chart. And so when I went into my pain management appointment yesterday, one of the things he said, oh, he's like, you've been doing your PT. That's good. He's like, you saw Raina the other day. He's like, I'm really good friends with her. And so then I said, well, my hands, and that sparked that conversation. And he's like, well, she's the best in the area. I'm glad you were able to get in with her, And so so talk about it. Sometimes I feel like I talk about all this stuff too much with my providers, but if I can glean any bit of information or interest out of them.
Don't be afraid to speak up. And a lot of times they may have a different perspective or contact or notice something different than what you've considered.
Yeah.
Because they are the specialists. We talk a lot about like how we've been disappointed in medicine, but also give your providers a chance, because those of us who do know about these things tend to be more helpful. Yeah.
Well, I'm glad I went for that eval because my hands were a lot worse than I thought they were. Oh. They really, really were. So,
and I think that's also self-gaslighting is maybe more dangerous than medical gaslighting. Yeah. Because we convince ourselves, oh, it's not that bad.
Yeah, it's not that bad. But then just this little change, this one little change. How many years ago could I have made this stupid ass change?
And it's so simple and affordable. She's talking about her chubby pencil. Yeah.
So anyway, that was a lot. Can we shut this down for today?
Yeah, that was a lot. So thank you guys for listening and working through the hEDS criteria worksheet with us. So what's next, Shelly? You're in charge.
Oh, just the way I like it. You know what? We've talked a lot about hypermobility, but we haven't really talked much about the things that go with it. So what if we take a break from this hypermobility stuff? What do you think?
What do you want to talk about next then?
Well, we touched on it a little bit. What about neurodivergence?
That's a great idea. That's
why I thought of it.
Yeah. We can take a poll on our TikTok and post it on our website. Do you guys want to talk about ADHD, or autism spectrum disorder. You guys vote and let us know.
Yeah, let's just see where the dopamine takes us.
It's a plan. Okay, we're done.
Yeah. Give me a step.
You looked pretty today.
Oh, thank
I think
you.
it's the clavicles.
Oh, so we want to know why I had to make this a boat neck?
Because it was too constricting.
Well, that's first problem. But the second problem was that I forgot to take the sticker off of it before it got washed, and it got washed and dried, and then it had like gummed up and like stuck on it, and it was like right up here, and I was like, well, I hate this stupid crew neck collar anyway, so I just made it like fun 80s.
We actually aren't done recording. We didn't do the closing.
I know, that's why I was confused, but it's fine.
Okay, so like stay tuned, and next time we will talk about the neurodivergent topic you picked from our poll.
Yeah. So thank you for listening to the Hacking Hypermobility podcast.
We would really appreciate it if you would take just a minute to share, follow, or leave us a review. It helps us grow the podcast and spread awareness.
Yeah. Our little TikTok's growing. We're almost to 500 followers. Did you see?
I checked. It was 444, which is a special number to me.
And 4 is my favorite number. Oh, I love it.
That's great.
Yeah. Well, we're going to wish you healthy hypermobility. Have a happy day, zebras.
Bye, zebras.
Bye.